So good morning. So also those who are joining us online. So this is kind of could be part one from two talks, but I thought I would go through the other side of the other part of Parkinson's disease. When we think about Parkinson's disease, we see these patients in the movement disorders clinic for the impaired movement control, but clearly it has emerged not only as a neuropsychiatric disorder, but essentially a systemic disorder. And so we'll go through several features, even though today I'll focus on the management of autonomic systems. So obviously that's one big part. And the other important features, including cognition, and so will be could be presented next time. So we'll split this talk into two. No disclosures to talk about. So really, we will first talk about different symptoms and then, of course, the management, which is our main objective today. So when we think about Parkinson's disease, and again, actually, it's interesting that we are kind of redefining how we diagnose these conditions. And I think that I'm scheduled to give another grand in November, where I will be talking about how Parkinson's disease is redefined or rather diagnosed. But currently, when we think about it's really more presence of two from three cardinal features: tremor, bradykinesia, rigidity. So that basically always means that, for instance, tremor may be missing. So it's two from three. There are some sort of secondary features, especially again reflecting impaired motor control. I would also point out asymmetric onset, which is very important. And the last but not least, it's the response to medications. Levodopa is, of course, the gold standard, and that's seen as a supportive diagnosis. There are some red flags when this may not be Parkinson's disease. There is a loss of postural reflex, balance difficulties, but it's important that this is not a early sign. So it's really more advanced. So if the patient presents with a falls, you think about other conditions, but again, this is not the main focus today. So the traditional view is that when you ask what is Parkinson's disease, is that this is loss of the Purging neurons in the pars compacta of the substantia nigra, which is correct, and that's one, and also presence of Lewy bodies. So you see those eosinophilic structures in a diseased, and it's also system asymmetry. So actually, we used to go to brain cutting when I was a resident in Michigan, and you can see only so much on brain cutting, but really for advanced Parkinson's disease, you could see with the naked eye, the loss of melanin, rich neurons. But again, this is something that's currently featured, and so we can think about as a striatonigral degeneration, which is an important concept for the treatment because again we supplement levodopa and other dopaminergic medications, agonists or sometimes indirectly, such as adenosine A2 antagonists, but that can really relieve a lot of motor symptoms. So this is older view and still partially true. Still, again, it's still the key for our symptomatic treatment of the disease. So again, as I said, this is one of the views, and actually the realization based on the Bragg's work and looking at the spreading of alpha-synuclein, it's very clear that the disease starts probably 20 years before usually patients present with the motor symptoms, which is basically motor symptoms what bring them. There are a few, now there is a big push for the preclinical or pre-symptomatic disease identification, because that will be the prime target for neuroprotective disease-modifying therapies. Again, this is not the target, and this is not the topic of today. And clearly looking at the sort of Bragg stage, when we sort of see somebody with the early signs of Parkinson's disease, they would be in a stage 3. So stage 3, when the alpha-synuclein sort of deposits, related to pathology with neuronal loss, dendritic loss, when it does reach the substation nigra and then stratum nigra projection. So that's what you would consider Bragg stage 3. So obviously it's a question of what's happening in Bragg stage 1 and 2. And the first nucleus actually involved is the dorsal nucleus of the vagal nerve. That's really the first nucleus, really first structure of the brain, which of course really begs the question why, and of course connection of or projections of vagal nerve into the gut, has opened very interesting possibilities. We know that vagotomies are done much less, but they were used to be done for treatment of gastric ulcer, and these patients have much lower incidence of Parkinson's. So again, this will be topic in October. I think November is my scheduled talk, but again, I just want to really point out that the structures before the substation nigra, are in brainstem, and again, it may kind of reflect few non-clinical motor symptoms, non-motor symptoms rather, which would really increase the risk. So very typical is isolated REM sleep behavior. Actually, a few patients we identified. Again, it's difficult because among other things, we miss sleep lab, but this is all what I will say. But there are clinical ways to diagnose REM sleep behavior, and that can be one hallmark that these patients are really on the trajectory to Parkinson's. The other one is actually constipation. Of course, doesn't mean that anybody or rather everybody who has constipation is heading towards Parkinson's, but again, we'll have some data we'll show today. So really, this is not much new. I mean, obviously, it was really first raised in about 1964 when sort of somebody would sort of say and write the attribution of such a complex clinical syndrome to a rather small and homogeneous structure as a substation nigra hasn't appeared to be logical. And again, as I said, this is really more systemic disorder. And so when you think about as a iceberg, so again, motor symptoms are maybe tip of the iceberg. Of course, they are moving very important. This is why these patients come to us. So this is but what sunk Titanic was really that hidden part. And again, there are very different conditions. Some of them are really, speech would be motor symptom, but again, sleep with the REM sleep behavior, anxiety, and mood disorders, for instance, those are really very important parts. So if you really take care of Parkinson's disease, again, just have to think beyond the movement. So what are those? So again, we will discuss today mostly autonomic dysfunction, but there is obviously a very important part of cognitive problems, which are usually later. Behavioral problems, sleep disturbances, I already mentioned REM sleep behavior, fatigue, which is my least favorite, and abnormalities of sensations, mostly the smell, actually. So it's interesting, when I was talking about dorsal nucleus of the vagal nerve, again, there is a lot of ideas, and Dr. Friedland has done very important pioneering work in terms of microbiota and really maybe spread of amyloid creating sort of proteins or promoting through that route. The other one would be sort of the smell, because a lot of these patients, of course, in the reports, sense of smell. Again, there is a theory of brain first and body first Parkinson's disease. Again, this will be all covered in November. So when you think about autonomic dysfunction and look at of course, we all know what it does, both parasympathetic and sympathetic nervous system, but you really can go through the whole list. But some of them are very, very pertinent for management of Parkinson's disease. So, dysphagia is kind of complicated or rather mixed, so there's some motor symptoms, so it's kind of combination motor symptom. But when you kind of go from the, pupillary response, that was used or tried to be used for the early detection. I'm not that excited about it, but again, it doesn't have any clinical consequences. But when we start from the top going down, sialorrhea, increased drooling. That's actually what, actually many times also have also these patients have a rhinorrhea, running nose, which is very difficult to treat. So we, for instance, I'll show you some, data and techniques how to potentially treat hypersalivation. Then there is some of these patients have a very impaired sweating. So patients who sometimes have to change their clothes 2-3 times a day, they would have this, and that has to do with the dopaminergic system. They would basically, based on their on-off system, they would have such a profound sweating that they look like they took shower. The gastroparesis is also more later symptom. It's very important and very, because it will then come to the motor fluctuations, especially some sort of delayed response to medication and skip dose. So again, solutions would be, bypassing the stomach. So new therapies are coming, hopefully including the subcutaneous pump. Currently, we have a way to bypass actual stomach by the duopa, which is a jejunal insertion of tube, and then delivery of levodopa to jejunum, where this actual absorption takes place. I already mentioned constipation, which is again, many times can precede. And when I got into the Parkinson's disease field, I never thought that I would know so much about constipation. Again, I'm not GI specialist, of course, even though we rarely refer, and frankly didn't find GI referrals that helpful. But that being said, we sort of really have a quite decent working knowledge of the colon program. And again, it's very interesting in terms of the microbiome, which again, as I already mentioned, is a very intriguing key or entry perhaps to the brain. Urinary dysfunction, urgency is it's mostly hyper, and that's also can be, of course, it's easy to treat than hypoactive bladder. And again, of course, we can use urology, but again, many times we try to do that. So this is a good idea when you think about when you go through the symptoms what these patients can be affected by. I haven't mentioned probably the most important thing, which we'll talk about, next, and that's hypotension. That's actually, so we'll focus on hypotension. So that's actually see up to 80% patients. It is very important that how we sort of approach hypotension, because basically we will be talking about neurogenic hypotension, and obviously, again, this will be covered in details. Some of them actually can be also postprandial after meals. Of course, we talk about the absorption of levodopa, especially in relationship to protein intake. But of course, these patients, many times patients can have a good lunch and they just faint, and it's not. There is a very important reason. Again, we will talk about it. So that's basically the next step, talking about orthostatic hypotension, which obviously, as we all know, relates to change in blood pressure or drop in the blood pressure upon standing. So the definition talks about 20 millimeters of mercury systolic or 10 millimeters in diastolic. But it's important that it's delayed. So we have 3 minutes. Actually, we can do immediate. But if you ask your nurses and medical assistants to do orthostatics, you should definitely do 3 and sometimes even 5 minutes. So the patient, so typically sometimes we sort of skip standing, but some patients cannot lie down, but even the change, but again, mostly from supine to standing. But again, that can be delayed. So don't, everybody's, we have to see so many patients, but give it some time. And again, usually, should be done 3 and sometimes after 5 minutes. So again, this happens about, more than half of patients with the Parkinson's disease, but not all of them are symptomatic. So, about 20%, 1/5 may be symptomatic, but again, this can be very disabling. And, but of course, one thing is to look at it would be the other medications. So of course, we know that these patients at age is a risk factor for Parkinson's disease, even though of course we have, patients that are 30s, 40s, but again, the vast majority would be, over 60. So that can be meaning they may have a presence of hypertension, and then that can be treated, but also think about some other classes of medications. I would point out alpha-1 blockers for the, especially men take it, for the prostate hypertrophy, which are also vasodilatory and actually can reduce the blood pressure. So first thing, of course, would be looking at the blood pressure. We'll be looking at medications, including blood pressure medications, I mean. So when we think about hypertension, and those who you think that I'm done with my internship, I'm done with this. Well, you're never done with that. But obviously, it's again, as I said, it's a fall in blood pressure, and really we kind of started to think about that as a sort of more neurogenic versus non-neurogenic. So non-neurogenic would be usually hypovolemia, cardiac insufficiency, or impaired return. And I will, we'll talk about how we can also distinguish that. So neurogenic, it would be currently considered really the norepinephrine failure. So for cardiologists, I would say the norepinephrine is their mortal enemy, in a way, the figure of speaking, in terms of if they would pick one neurotransmitter, they would probably pick norepinephrine. Obviously based on the sort of, again, mostly blood pressure. So again, sometimes I joke that I feel like Dr. Jekyll, Mr. Hyde, even though nobody hopefully will be killed or die. Dr. Jekyll, Mr. Hyde, when we sort of try to reduce blood pressure, but in Parkinson's clinic, many times we just do exactly the opposite. It's interesting. It's important to think about, and again, we'll get some more data about the sort of the cascade when the autonomic failure happens, and there are actually three major conditions, but you have to kind of think about, is it a peripheral problem versus central problem? So I've done talk about MSA, maybe, I don't remember recently. So again, that's a multiple system atrophy. Again, just sort of historical footnote. I trained in the University of Michigan, that Dr. Gilman was sort of an expert in MSA. And if somebody said multiple systems atrophy, you would be in doghouse for, but it was about 6 months jail time in a doghouse. So it's multiple system atrophy. And that's the idea of the central failure. There is a pure autonomic failure, which we don't see much. And also, again, these patients are also, many of them are predestined to develop either Parkinson's disease or multiple system atrophy. Again, one of the few, many holes in our sort of current portfolio is in, again, autonomic clinic. And again, so obviously there's a subspecialty in neurology. So again, those who are, and again, you can really bridge a lot of peripheral neurology versus central neurology. So this is something to consider. And again, because these patients, if they are really symptomatic, about 1/5 of patients are, it can be very disabling. And of course, there's the iatrogenic, I mentioned vasodilators, again, also not only antihypertensive, again, nitrates, I mentioned already, alpha-1 agonists, but also some more commonly used, again, tricyclics can be also having some hypertension. So those you have to go to the list if you try to analyze potential causes, and of course then the treatment. So what happens when we stand up? So actually, if you ask somebody to stand up, so what happens that obviously, there's gravity, and that would kind of result in a potential decrease in venous return to heart, and that leads to cardiac output. So if somebody faints, what do? You don't keep them up. You just put them, supine and really elevate legs. I remember when I was a medical student, we went for trip, and one of my classmates, she fainted, and she was lying down, and we had some very arrogant assistant, with us, assistant professor, who just came to her and kind of like with his foot kind of really lifted her legs up, and I felt like, what a jerk that he's not helping her, but actually he was helping her a lot. So that was really what she needed to wake up. But again, that's the idea of the reduced return to brain and the reduction in cardiac output. But of course, if you stand up, you trigger venous and arterial receptor response, and you have a sympathetic activation, which leads to the constriction and increased venous return. Important part I want to emphasize that is the heart rate. So again, I went to that idea or example when you ask, your MA, please, can you please run the autonomic, the orthostatic blood pressures? And they bring you blood pressures. There is no heart rate. Useless. Or rather, not very helpful. Maybe again, I already talked about delayed. 3 minutes, maybe 5 minutes. But again, the heart is very important because it's not only what happens with the blood pressure, but what happens with the heart rate. And that's actually coming to that sympathetic response, because obviously, what is the reason? What is the sympathetic response? I mentioned that cardiologists may consider norepinephrine mortal enemy. It's tachycardia, increase heart rate. So that's very, very important. And again, this is of course regulated by autonomous nervous system. This happens without our will control, of course, as we know. And again, norepinephrine is the main, again, in this situation, our main friend, and not the enemy. And again, so basically, this is a basic definition. And we kind of think about the, central or neurogenic rather, neurogenic. That's very important. So actually, when I was training, we didn't really talk about neurogenic orthostatic hypotension. It was only orthostatic hypotension, but again, kind of think about, because it really gives you potential treatment. And so kind of think about. So we don't routinely measure norepinephrine levels, but that's something you can do, and that's more advanced autonomic sort of workup. You can get you can actually measure your norepinephrine levels, lying, standing. So it usually requires admission because you need to really regulate the body position. But that's one way to do it. But you can sort of do the Pursman, assessment without actually getting norepinephrine level measured or assayed. And the symptoms really happen, as I said, when the blood pressure falls. So this is actually in the first upper row is a transcranial Doppler of the blood flow. So, and you sort of see how the hyperperfusion, basically the median blood pressure changes. And again, these patients with a drop more than 20 systolic and 10 diastolic may cause some symptoms, which basically again would be positional. So that's very important when these patients tell you I'm dizzy. So when a patient comes and doc, I'm dizzy, of course, we're getting dizzy because it's so many, many things. So it's very important to really tease out. And one of the things you need to really ask the patient, if they are not really volunteering, to say that if it's really related or associated with a body position. So what are the symptoms? Of course, we all think about on our left side, think of lightheadedness, dizziness, pre-syncopal and actually syncopal events. That's clear, So, and of course, we deal a lot of with the seizure versus syncopal event, of course, and then things coming like posictal state, yes or no. But those are clear or relatively clear symptoms, but it can be more complicated. It can be sort of more subtle. And so some patients may feel background weak when I stand up, because there can be many things. Fatigue, leg buckling. Some patients talk about brain fog. Again, that can be, almost, it's not endless, but nearly endless list of causes. Visual blurring, could be headache, could be neck pain. There's actually very specific neck pain called hanger, so it goes to neck and shoulders, like hanger. So that's sort of sometimes, again, those are things we typically would not typically associate with the symptoms of hypertension. But again, that's why you need to really try to get a circumstances, the pattern. That's many times we try to identify the pattern. And again, would be the activity, blood body position. And of course, you can, if you are suspicious, you may or you should measure blood pressure values. Again, it's mostly happens upon standing, can be more complicated, but that's basically usually so. Again, my first patient with Shiny Traeger was a resident in Europe. That patient couldn't even sit, so basically he would faint sitting. Again, and it was unfortunately a long time ago. So kind of dates me. Actually, at the time we call MSA Shy Traeger syndrome, which is still my preferred term, but of course MSA is the term. So it can be very disabling, but of course this was, this was MSA, the Parkinson's, but again, the consequences of orthostatic hypotension, or rather I should say neurogenic orthostatic hypotensions, are same. Usually, so typically patients will report that early mornings are worse. It has to do with the sympathetic versus parasympathetic tone in the morning. And as I mentioned, it can be postprandial. And again, that splanchnic sort of pooling of blood may aggravate that reduce venous return and subsequent hyperperfusion of the brain. So the management, again, it's not everybody who has blood pressure change needs to be managed. But again, some patients may be symptomatic, and we usually typically start with a non-pharmacological approach. The first question: how much do you drink? How much liquids do you drink? Especially, we are kind of after heat wave, and Ohio River Valley is pretty steamy and hot. So how much they fluid intake. And some of these patients tell me I have like 16 ounces of water per day, about. And plus I drink a lot of iced tea, being south, and of course, tea having caffeine, being diuretic. So you sometimes really need to go through not only amount of fluids and type of fluids. In coffee, same thing. So, so again, fluid intake and salt. So some of these patients are really pleased when you tell them, oh, you can just go for chips or other sort of quote unquote junk food. We try to, again, that idea of Dr. Jekyll, Mr. Hyde, without any killing, is here. So usually, management, of the essential hypertension could be salt intake reduction. Here you just go the opposite way. But again, the idea is basically that you increase the kind of buying of water. And of course, if there are some aggravating factors, for instance, postprandial, you really can talk about the portion size. So, so if somebody likes to eat twice a day, so maybe spreading the food and things like that. So these kind of modifications can go. And last but not least, for the non-pharmacological would be, compression stockings, which especially Parkinson's is more common in males, and they just hate it. They, of course, wearing that in the summer is not very pleasant, and also for keeping room cooler. Actually, a few patients I wrote letters. I'm not sure how useful these letters were, but basically they had a very high air conditioning bill because they would run their air conditioning at 65 degrees. They don't faint, and of course the electricity, bill went through the roof. And so, we kind of, I wrote quite a few letters kind of stating that they need to do that, how help, to get some relief from their energy bill. I'm not sure how useful that was, but again, I still probably have that template somewhere in my files. But when you think about pharmacological approaches to really, so this is the first. So again, fluid intake, salt intake, some modifications like, postprandial and compression stockings. I didn't mention the compression stocking should be thigh high, so not knee high. Knee highs are really useless for this purpose. It's kind of not pleasant, actually. I had to wear them after my knee surgeries. They asked me to wear them 4 weeks. I did it, being compliant, unusually for me. And it doesn't feel right. It's painful to me. But again, so you can take and kind of step up the game and go into the pharmacological approaches. Again, you can either expand intravascular volume or increase vascular tone, or you can do both. Actually, many times it's best to do both. So again, these things are not mutually exclusive. We just really try to do it step by step. So I already mentioned, I don't prescribe salt pills that often. I have. But again, I usually kind of go quote unquote junk food. It's interesting actually sometimes, some patients who actually cook for themselves, they really, would reduce salt to extreme. Of course, the other thing can be hyponatremia, which probably see somebody coming with a 122 sodium when they're seizing. So vasoconstriction, the typical older medication would be alpha-1 agonist. So midodrine or proamortine is commonly used. And of course, the newer medication, I'm not sure we should be familiar with the droxidopa or Northera. But again, the issue is also the supine hypertension. I spent some time. So again, it's not only when you think about autonomic dysfunction or neurogenic orthostatic hypotension, it's not only, so far I was talking about only orthostatic hypotension, which is, what's symptomatic. However, I would rather compare it to roller coaster ride. So that's actually this kind of dysregulation. And many of these patients may have a really jumping blood pressure up and down, can be very difficult to manage. So sometimes you have to manage really PRN, and you have to be very careful to not to cause supine hypertension. So for instance, if somebody takes Northera or midodrine, last dose shouldn't be after 6 p.m. Patients shouldn't even, shouldn't lie down if they take a nap. Would be kind of lazy boy type of situation. Many times also you recommend wedge, or 2 pillows, but the wedge 30 degrees. Try 30-degree wedge. It's very uncomfortable to sleep, and this was for me. But sometimes you just want to really prevent that patients are flat. So again, the elevation of 30% can reduce supine hypertension. So there are two schools of thoughts about supine hypertension. Many of them would be very permissive. That doesn't really do much. But again, we know that Parkinson's has, can be aggravated by also microvascular changes, Y-matter changes. So I tend to be very hawkish about management of supine hypertension. I actually prefer captopril, which is not much used ACE inhibitor anymore, but it's short life. It's short half-life, I mean. So, usually lisinopril and other sort of ACE, even though actually a lot of cardiologists moved away from ACE inhibitors, but more for the receptor blockers. But again, the captopril, for instance, because of half hour, about 6 hours, can be very, very useful just for the bedtime, and then basically just so that when they wake up, the captopril should be on the system. Nitropase can be another thing, which is kind of more difficult to dose, but you can do some nitropase. Again, you just remove the the patch before they wake up. I mentioned increased fluid retention, so fluorocortisone, Florinef is basically another sort of mineral corticoid. Again, can cause some edema, supine hypertension. Usually doesn't work longer than 6 months, so I don't use it as much. But again, vasoconstriction to me, with the midodrine or Northera is more plus non-pharmacological approach would be more useful. So obviously very important, so looking at the postprandial, you just so looking at the sort of meal and water. So you see that again, we talk about that postprandial effect, which also you can kind of explore to advantage for the management. So again, many times you need to really, the patient walks you through his or her day, and sort of you can really dismodify. So many times you become as a lifestyle coach, and so that's something also to consider. Let's skip this because of the amount of time, but again, this is sort of the same idea of the postprandial, and with Dr. Friedel, we just talked about Africa for other reasons, and my favorite food when I go to Africa, Zambia. Most I used to work in Zambia, few times. It's called Shima, or if you speak, so that's more Nyanja language. But if you go to Zimbabwe, or Rhodesia, if you go to Zimbabwe, in Shona it's called Sadza. Actually, so Dr. PH probably knows what Sadza means. So that's one of the only words from Shona I know, because it's actually. But anyway, so I like the Shima, which is actually porridge. They would say maize, we would say corn porridge. And we would have this, big food, and so basically you would be in Shima coma. And anytime you have lunch in Zambian hospital, so you'd be in coma from 12 to 2, and that was actually postprandial hypotension. So that's actually my favorite postprandial province, Shima coma, and I can really wait to go back to Africa and have some Shima there. But anyway, I digressed. So going back to neurogenic hypotension, one thing is to also think about it would be, in looking at the efferent sympathetic pathway, again, the central versus peripheral, again, MSA, and again, I'm just trying to think, I must have given talk, even though I don't remember specifically, but I have, specific talks about MSA, but it has to do with its pre-ganglionic or post-ganglionic. That's very important because there are some new medications being tested as a norepinephrine reuptake inhibitors, and of course you need to have a really sympathetic ganglion preserved in order to work. But when we think about really typical Parkinson's, it's a peripheral autonomic failure, so it's not central. And so it's really that, of course, the peripheral neuropathies, amyloid neuropathy, as Dr. Brown here. So of course, that's a diabetic neuropathy, because the most common probably can cause the same problem, but it can really gives you some guidance for the treatment, and again also for the norepinephrine levels. So when going back to Parkinson's disease, again, we are all well versed in dopamine replacement. I already mentioned substantia nigra and Bragg hypothesis, but sort of same thing would be, the vasoconstriction would be really also treating norepinephrine. Of course, norepinephrine can also some interesting parts on gate freezing and other problems. But again, here would be just purely as a vasoconstriction in the postganglionic autonomic sympathetic nervous system. So I mentioned Northera a few times, or droxidopa. So this is basically same idea. It's a prodrug for norepinephrine. So again, we should all know levodopa, which is again, with a decarboxylation leads to dopamine. Again, we don't give patients dopamine because it doesn't cross blood-brain barrier. Same thing for I mean, yeah, there is a few, of course, few area postrema and some other things, some other areas of BBB, but again, this is not feasible for the pharmacologist. So you have to get a prodrug, so it can be really, it can get to the central nervous system or peripheral nervous system. And again, so droxidopa will be there is added hydroxyl group, and again, it goes through same process of decarboxylation. So when you treat these patients with the droxidopa, you should block the peripheral decarboxylation with the carbidopa. So many of these patients have, on Cinemed, which is carbidopa-levodopa. So you need to really, because otherwise the aromatic decarboxylase periphery activity is such that that medication would be, basically useless. Probably you've all seen, you should have seen movie Awakening, where obviously they kind of discovered levodopa, but they realized the levodopa stopped working because they had to give so many grams, really, the medication, and before the decarboxylation was discovered, and the blockers such as carbidopa. So again, and this is the product for norepinephrine, which is again the medication approved currently for treatment of neurogenic orthostatic hypotension. So again, it's not for the hypovolemia. And again, as I said, think about heart rate, if you don't have a more complex and complicated autonomic evaluation available. So this is this was a sort of a slide from the pivotal trial leading to the, it was a very short trial. So we used Northera. So this medication is warning there is no data after 8 weeks, if I remember correctly. Of course, we use it long term, but it's actually done 3 times a day, and you start with usually 100 milligrams TID, and usually the highest dose will be 600 milligrams TID. So you can really measure blood pressure. So the patient need to be, or other caregivers, and both need to be instructed to measure blood pressures, because again, supine hypertension. So few patients may have actually I induced few patients with a hypertensive crisis, so you have to be very carefully. So, again, you have to be very, but this is not usually first-line drug. But again, I think that I kind of move from midodrine to droxidopa as soon as I can. It's kind of a poorly covered, even though it's generic, but something would I really consider very useful. So that's one of the indications. And so not sure but again, if you don't prescribe this, you should be aware of this, again, prodrug for norepinephrine and how it works. A sort of similar thing would be sort of, it's interesting that, the medication wasn't really approved based on the blood pressure. So, you have to kind of realize one thing: you are not treating blood pressure. Some patients can be carried away. And some of these patients are obsessive who have Parkinson's disease, especially in dopamine. So they bring these logs and of blood pressures, but you treat the symptoms. So that's very important. So it's not only the blood, of course, you need to make sure they are not hypertensive. I already mentioned supine hypertension. Again, as I said, if it's done TID dosing, the last dose shouldn't be after 6 p.m. But think about treating the symptoms. And again, we already went through the symptoms of dizziness, fatigue, or maybe some, like brain fog and all these things. So you identify the target symptom, and that's really many times the improvement. So sometimes you see blood pressure change, which would correspond to expected, in your sort of association that it will improve or increase and the symptoms improve. I've seen also patients report improvement without really moving blood pressure much. So again, that's why you just don't have to escalate the dose based on blood pressure, but based on symptoms. That's very important. And but because it's very difficult to, again, measure, again, some patients would, again, be careful, they can be carried away. They bring you like really, or email you like, have you seen my blood pressure on December 1st at 5 p.m.? Maybe I know I didn't, because it was like 500 values. And again, but of course, there definitely, this is not only treatment of symptoms, there is definitely change in blood pressure, and again, standing, there is no, the mean change may not be that high, but many times having systolic blood pressure 68 versus 78 makes a big difference into the symptoms. So again, you don't treat blood pressure, you treat the symptoms. Again, so I mentioned, titration. So maximum dose would be 1800 milligrams. I went higher than that, and it has, off-label, and again, has to do with the decarboxylation. So, but they're going to be very careful. Also, we tried it for gate freezing. It didn't really work, but because there is also some additional role of norepinephrine. But again, and again, I already mentioned the management of supine hypertension. Again, captopril is my drug of choice. Yes. Yes. So again, yes. So again, again, as I said, these patients, again, I'm talking mostly Parkinson's disease, but you need to. So if you have indication of non-Parkinson's disease patients, again, they will take levodopa, so it's kind of given. But that's a good point. If you use for other indications of therapy, you need to include, so you can get carbidopa. It's called low dosing. It's actually expensive. It's a really penny item, but that's a good point. So if your patient doesn't take carbidopa, which again, Parkinson's disease, essentially everybody does, but you need to, you need to introduce, it's probably 50 milligrams TID of carbidopa is plenty to really block that. So, but that's important because decarboxylation would really, so you would have a much less response. And again, you want to really reduce this peripheral decarboxylase action. Yeah, I'm not sure what Cuban, we like that. I'm not sure it covers droxidopa. No, I mean, Northera. No, Mark Cuban, obviously, whatever you think about him, so I don't know if low dosing is on his list, on list of his medications, but we actually, it's a good point, actually. So those of you don't know, they have really decent prices for a lot of important medications. But again, I'm not sure whether carbidopa is there. So this is all you always wanted to know about neurogenic orthostatic hypotension, but you were afraid to ask. So unless you are not afraid to ask, I don't know. Oh yeah, of course. I'm just paraphrasing Woody Allen, of course. sensitivity, because it can be. Oh yeah, yes, that's correct. That's a good point. Of course, a lot of patients cannot, yes, actually, absolutely. So it's sensitivity, so it can be delayed. But of course, correct. So I have patients who we hardly can stand up. Actually, that's a very good point. Thanks for the clarification that if you get a response before, you don't have to really let the patient faint in front of you. But that's correct. So it's if you don't see the drop, I wouldn't leave it there. So it's sensitivity of the test. But again, we have a patients, getting Shelley, of course, they are, but they are strong women, and sometimes we have patients we cannot, hardly stand up for a few seconds. So, but correct, that's an important point. If you get an answer before, you don't have to really wait until patient faints. So that's. Yeah, thank you. So other GI problems. Again, I mentioned that I never thought I would know about this. So I talk about sialorrhea. We'll talk about rhinorrhea, which is my least favorite. So it's very interesting that a lot of these patients come and his nose is running. It doesn't make sense. It makes perfect sense to us. Of course, one thing we kind of know about runny nose could be Bell's palsy or the recovery from Bell's palsy, which is different. Of course, it's a peripheral lesion. And of course, you probably know the syndrome of crocodile tears. The syndrome, so when you have so it can be also increased lacrimation, but here it's literally from the parasympathetic sort of, really, or sympathetic, parasympathetic, misbalance, if you will. Again, dysphagia, again, it's kind of complicated because it's also more symptom. And of course, gastroparesis, and last but not least, constipation. This is probably what body will, actually, let me look at, oh gosh. Sorry, time has been, so actually we are almost, let me go through a few things. And then I guess we have to split this talk. So this is almost like Scheherazade, having this 1001 stories. So we have to split it. I have actually 106 slides. Of course, that I knew that talk will be split into two. I thought two halves maybe would be like this will be 1/3. So sorry, I cannot really. But I would rather go through details of certain aspects rather than go through everything and then basically have this mishmash in your head and nothing really sticks. So we can sort of again to be continued. But again, let me briefly cover some symptoms before we take some time for questions. So again, we have issues of dysphagia, salivary, so drooling, and again, drooling is not. It's not something what these patients come with a BIP, many times. ALS is of course another example. Again, so you see this patient. So so there are ways to treat it, and again, it's not something what you would just kind of notice, But again, nausea, which is usually from of course, many times these patients may be nauseated from medication, levodopa. That's why droxidopa also, droxidopa, carbidopa, I apologize. Carbidopa also blocks nausea by reducing the carboxyl activity. Of course, you have to be very careful with the nausea and Parkinson's disease because many of them are actually dopamine blocking agents. Reglan is if I talk about my enemy, figure of speaking, that's Reglan, metoclopramide. I like that dyskinesia. It's kind of well, I don't like it, but I enjoy, but we have a lot of patients actually Reglan. And so again, metoclopramide. If you see Parkinsonism, so you have to be very careful with the nausea medications. Actually, the best medication is domperidone. I'm not talking champagne. I'm talking domperidone, which is only peripherally acting dopaminergic D2 blocker. So it does not cross blood-brain barrier. It's unfortunately available only in Canada. I mean, not only, but for us, it would be Canada. Again, I mentioned that I'm trained in University of Michigan, so it was very easy for us to get these medications. You just send patients from Ann Arbor to Windsor, Ontario, and the question was, do you go over the river taking the bridge or you take the tunnel? That was the only question, to decide. But you got a lot of medications, from Canada, kind of making me nostalgic again. So, but domperidone, but again, be very careful about nausea treatment in Parkinson's disease patients because again, you can really cause Parkinson's. Again, Reglan is sort of, as I mentioned a few times. And then, of course, constipation. That's just, of course, and that's again GI motility. So let's do this. Let me tell you about treatment of sialorrhea, and that's it. And we will sort of, we'll take a break. So again, this is something, men more affected, but of course, men have more Parkinson's disease. Can be sort of mild, but again, but you can see sometimes this patient come and do basically, like dried saliva, and it's really actually also when these patients come as a first symptom. So this is something what again, I see patients coming in the people, they will have to change the shirt or the clothes, so it can be pretty profound. And again, so really, I want to just talk about toxins. So because you can do Robinul. Robinul is actually anticholinergic, but it's quadricyclic structure, so it does not cross blood-brain barrier. Of course, many times you get this warning that you are giving anticholinergic medication, antimuscarinic medication to somebody who is elderly. So of course, but you have no central muscarinic effect because it doesn't cross blood-brain barrier. So Robinul is one thing, but and actually, again, my favorite would be, favorite, that's what I do, is a toxin. And so those who you rotated, again, so again, actually, I prefer, so the indication is Xeomin, Botox, but my prefer is actually my blood, which is type B, which actually targets synaptobrevin, and so it's, it's type B. It tends to burn, but has much stronger anticholinergic effect. But basically, you inject. No, really, as the cartoon. I don't have a video. Yeah. So here, here basically just gonna really tell you about the angle. Obviously that's a really busy real estate. So you have to be comfortable and knowledgeable, I guess, doing that. And also, when we were like again doing dystonia, structural muscle, and so this is a very busy neighborhood, very busy real estate. But again, it's getting masseter, and about the masseter, if you do EMG, would be EMG silence and submandibular so it's really relatively easy. I never had the complications, and patient can have a good so usually it's done every 12 weeks. Again, I prefer, there is no head-to-head study, but I prefer serotype B, which again has a little bit better. But again, Ababo, which is the Botox, and Inco, which is the Xeomin, can be used as well. And so let me. Okay, so actually, so this is just basically approval of the Xeomin and Botox, and let's stop here. So apologize that again, but as I said, I would rather spend some time in details rather than give you this kind of list of like you would read War and Peace by Tolstoy in about 1 hour. You probably wouldn't remember much. Anyway, so let's stop here and let's see if you have any questions. So I'm still sharing. Okay, yes, Dr. Brown.
So is the problem with Thiolia in Parkinson's, is it just another manifestation of hypokinesia?
No, it's hyperproduction. I think it's actually there's a good question. So actually there's it's not only swallowing, but it's also hyperproduction. So in ALS, it's typically I think more like trouble swallowing. Here is really more, but also the runny nose I mentioned, rhinorrhea. So it's more really like the sympathetic parasympathetic, it's so imbalance. So it's really increased production. So it's not only really, that's a good, again, it still would probably treat it similarly, but it's actually because, many times this patient didn't complain of dry mouth, but, in Parkinson's disease, many times that's not the case because, again, they just make way too much saliva. And so you kind of reduce that. So it's more hyperproduction.
Thank you, Peter. One remarkable fact is that James Parkinson wrote his book in 1817, ended with a conclusion that the disease starts in adults. And how he figured that out, I have no idea.
I didn't know that. I mean, it happens to be true, and I don't know. Actually, I have to confess, I had never heard this. So nobody reads that essay anymore. I mean, many people would pretend it's like you pretend you read War and Peace, but nobody. Anyway, so that's actually I have to confess, this is the first time I'm hearing that. And I don't know, but it's true. Those nucleus of vagal nerve, again, it's basically important for your work in terms of the microbiota, but I have no idea.
The book is available for free as a PDF.
Correct, yeah.
Both of us in this field for several decades. Why didn't we all know this 30 years ago? I know one of the things to talk about the context.
Again, basically, I think because these Parkinson's patients were treated by movement-disorder neurologists, and we were probably just more like we were boxing, so again, you need to be a physician, of course, and again, it was neglected. It's absolutely correct. It was neglected, or wasn't, now, when you sort of look at the quality of your care, how you take care of, and again, we have a whole bunch of things about non-motor symptoms, talk about later on. So again, I just think that many times when you look at this sort of like, looking different symptoms, depends on what specialty or subspecialty, I should say, really, or the patient. So, it doesn't really reflect on us very well. Of course, we caught up as a field, but it's true that even during my training, and again, I'm not that old. My hair is from my twin girls. But I don't think we've talked much about REM sleep behavior. I mean, I'm just trying to remember, I don't think that we sort of heard much about REM sleep, and it's not that long. I mean, it's not a long time ago. So no, again, good question. And the good thing we caught up. And again, it's really that seeing Parkinson's is a systemic disorder. Again, I'm not trying to meddle into GI field, or urology field, not at all. And of course, I know where are my limits. But again, you can take care of the symptoms and again identify. So that's actually, or if you don't want to treat them, just at least talk to them and then refer to the needed subspecialty. But again, I think it's just we were kind of really boxed into the fascinated by freezing and really totally forgot these patients yell in their sleep. Ali, you had a question. Well, so again, this will be. I'm preparing a special talk about this for November. So correct. So basically, there is basically, actually there's a skin test, a skin biopsy test. I mean, correct. But you can also distinguish MSA. So how about stay tuned in November? So there will be special talk about this, how we redefine Parkinson's disease. But clearly there is again, you do simple. I mean, we don't do it. I'm not sure Dr. Holiday is on. We don't do it routinely yet, but it's Norton does it. I'm not sure why. If patients are not needed, but correct. So you can really but the peripheral alpha-synuclein deposits, phosphorylated alpha-synuclein is something what can see in sympathetic nervous endings. So again, skin biopsy is one way. Again, stay tuned in November. All right, so I'll stop sharing. Do we have any questions from the? I hope I didn't put everybody to sleep. So again, to be continued. So I'll remember where we stopped because I have sort of like I thought about like 2 hours for probably Thursday, but again, as I said, I thought maybe spending sort of more details, more granular information, and go from there. So again, thanks so much for joining us both physically and virtually, and let's go to see our patients.